Hi everyone, welcome to my channel, Integrated Med Notes. In this video, I will discuss about carcinoid or neuroendocrine tumors, neuroendocrine cells, and carcinoid syndrome. Let's start with the comparison between carcinoid tumor and carcinoid syndrome. Carcinoid tumor is just the presence of a tumor or a mass in the gastrointestinal tract. On the other hand, carcinoid syndrome is a syndrome, so a constellation of symptoms such as diarrhea, wheezing, and skin flushing. These symptoms are due to serotonin and other bioactive compounds released by the carcinoid tumor. If the tumor remains confined to the GI tract without metastasis, the liver metabolizes these substances before they can enter the systemic circulation, preventing the development of carcinoid syndrome. Carcinoid syndrome occurs when the carcinoid tumor metastasizes to the liver and serotonin bypasses liver metabolism to enter the systemic circulation. We'll explore both carcinoid tumors and carcinoid syndrome in more detail later. Carcinoid tumors are neuroendocrine tumors. Neuroendocrine tumors arise from neuroendocrine cells. Now let's discuss about neuroendocrine cells. Neuroendocrine cells are specialized cells that combine features of both the neurons and endocrine cells. Neurons communicate with each other via synapse. An endocrine cell is one that receives chemical signals from the blood and releases hormones in response to the chemical signal. Neuroendocrine cells are activated like neurons since they receive synaptic input from neurons, but they respond like endocrine cells by releasing hormones and biogenic amines into the bloodstream. Neuroendocrine cells are also called APUD cells, short for amine precursor uptake and decarboxylation cells, because they can take up amine precursors such as DOPA and 5-hydroxytryptophan and use the enzyme decarboxylase to convert them to certain amine hormones such as dopamine and serotonin. On electron microscopy, neuroendocrine cells are characterized by dense core neurosecretory granules that contain and stain positive for chromogranin A, neuron-specific inolase, synaptophysin, and CD56, or neural cell adhesion molecule, which are typical immunohistochemical staining markers for neuroendocrine tumors. Neuroendocrine cells secrete a variety of biogenic amines and hormones, like serotonin, histamine, bradykinin, and prostaglandins. The release of these hormones can also be regulated by other hormones. For example, somatostatin is a hormone that is made by cells in the hypothalamus as well as the gastrointestinal tract, and it inhibits the release of a number of hormones from neuroendocrine cells, including serotonin. Embryologically, neuroendocrine cells originate from either the neural crest or the endoderm. Neuroendocrine cells are found distributed throughout the body in different tissues, and they include neuroendocrine cells of the GI tract, called enteroendocrine cells, pancreatic endocrine cells, or pancreatic islets of Langerhans, pulmonary neuroendocrine cells, also known as bronchial Kulchitsky cells, the parafollicular C cells of the thyroid gland, and the cells of the adrenal medulla. The neuroendocrine cells of the gastrointestinal tract are called enteroendocrine cells. Enteroendocrine cells are modified epithelial cells located in the crypts, and they secrete a variety of hormones. Enteroendocrine cells include G cells that secrete gastrin, D cells that secrete somatostatin, Enterochromaffin cells that secrete serotonin, Enterochromaffin-like cells that secrete histamine, etc. Enteroendocrine cells that stain with chromium salts are called Enterochromaffin because they have affinity for chromium, hence the name Enterochrom-affinity. When enteroendocrine cells stain with silver salts, they are called argentaffin cells, from the Latin argentum for silver. Based on their location, neuroendocrine cells have different functions. In the lung, the Kulchitsky cells help modulate airway tone. In the gastrointestinal tract, enteroendocrine cells regulate digestion, motility, and nutrient absorption by releasing hormones such as gastrin, cholecystokinin, vasoactive intestinal peptide, or VIP, glucagon-like peptide 1, or GLP-1, and serotonin. An abnormal proliferation of neuroendocrine cells can lead to the development of neuroendocrine tumors. Now let's talk about neuroendocrine tumors, or NETs. Neuroendocrine tumors are a group of neoplasms that arise from neuroendocrine cells. They include the gastrointestinal tract neuroendocrine tumors, pancreatic neuroendocrine tumors, or islet cell tumors like gastronoma, insulinoma, glucagonoma, somatostatinoma, and VIPoma, pulmonary neuroendocrine tumors such as bronchial carcinoid tumors and small cell lung cancer, medullary thyroid cancer, neuroblastoma, and pheochromocytoma. Neuroendocrine tumors that arise in the tubular gastrointestinal tract, bronchopulmonary system, and rarely in the genitourinary tract, such as the ovaries or kidneys, are collectively referred to as carcinoid tumors. Many neuroendocrine tumors secrete large amounts of hormones. Interestingly, they also tend to overexpress somatostatin receptors, especially in the gastrointestinal tract, which has significant therapeutic implications, as it allows the use of somatostatin analogs for treatment. On histology, well-differentiated neuroendocrine tumors show tumor cells arranged in a rosette pattern. The tumor cells have scant eosinophilic or pink, finely granular cytoplasm and round to oval dark nuclei with a salt and pepper chromatin pattern. Additionally, the tumor cells contain neurosecretory granules visible by electron microscopy and stain positive for neuroendocrine tumor markers such as chromogranin A and synaptophysin. The treatment of neuroendocrine tumors includes surgical resection and therapy with somatostatin analogs. About pulmonary neuroendocrine tumors, please check out my separate video on lung cancer for more details. In this brief discussion, I'll note that neuroendocrine tumors of the lung include both small cell lung cancer, SCLC, and bronchial carcinoid tumors. Now let's discuss about carcinoid tumors. Carcinoid tumors are well-differentiated neuroendocrine tumors, or NETs, that commonly arise in the tubular gastrointestinal GI tract, about 55%, the bronchopulmonary system, about 30%, and less frequently in the genitourinary tract, such as the ovaries or kidneys. They are called carcinoid because these tumors appeared morphologically different and clinically less aggressive than the more common gastrointestinal tract adenocarcinomas. As Dr. Gulgen points out, the suffix oid means it looks like, but it is not exactly, implying they look like carcinomas, but in fact they are carcinoids, distinct neuroendocrine neoplasms. In modern use, the term carcinoid tumor is still used to refer to well-differentiated neuroendocrine tumors arising in the lung, but the WHO prefers to call the carcinoid tumors within the gastrointestinal tract as well-differentiated neuroendocrine tumors, or GI NETs. For simplicity, we'll continue using the term carcinoid tumors in this discussion. Carcinoid tumors are typically slow-growing, low-grade, well-differentiated neuroendocrine tumors. Their metastatic potential correlates with tumor size and depth of invasion. Tumors larger than 2 centimeters and/or those invading beyond 50% of the bowel wall thickness carry a higher risk of metastasis. While they can occur anywhere along the GI tract, the appendix and ileum are the most frequent sites for carcinoid tumors. The appendix is the most common location for GI carcinoids, and these lesions are usually smaller than 2 centimeters, thus carrying a relatively low risk of liver metastasis. However, carcinoid tumors of the terminal ileum are more likely to metastasize to the liver and cause carcinoid syndrome. Carcinoid syndrome arises predominantly from small intestinal carcinoid tumors that metastasize to the liver, allowing vasoactive substances such as serotonin to bypass hepatic metabolism and enter the systemic circulation. In contrast, foregut, such as gastric, duodenal, and hindgut, rectal carcinoid tumors rarely metastasize, and hindgut carcinoids typically do not produce serotonin to cause carcinoid syndrome, even when they metastasize to the liver. This is because they lack the enzyme dopa decarboxylase and cannot convert 5-hydroxytryptophan, 5-HT, into serotonin. Overall, carcinoid tumors are the most common malignancy of the small bowel, more common than small bowel adenocarcinomas. They frequently appear in the terminal ileum, can be multifocal, and often metastasize. Most small bowel carcinoids secrete serotonin, leading to carcinoid syndrome once they metastasize to the liver. On gross examination, carcinoid tumors of the gastrointestinal tract typically appear as well-circumscribed, polyp-like nodules located in the submucosa or extending into the muscularis propria, and may even invade deeply into the mesentery. They usually have a yellow color. The secretion of serotonin by these tumors induces fibrosis of the bowel wall, a desmoplastic reaction that can lead to kinking and obstruction of the small intestine, particularly in the terminal ileum. Histologically, carcinoid tumors are characterized by nests of tumor cells arranged in a rosette-like pattern, meaning the cells are organized peripherally around a central lumen. The tumor cells have eosinophilic or pink, finely granular cytoplasm and round dark blue nuclei with a salt and pepper or stippled chromatin pattern. As we have discussed, salt and pepper chromatin is typically seen in neuroendocrine tumors such as medullary thyroid carcinoma, carcinoid tumors, and pheochromocytoma. Ultrastructurally, electron microscopy reveals that the tumor cells contain dense core neurosecretory granules in the cytoplasm. Immunohistochemically, these tumors stain positive for neuroendocrine markers such as synaptophysin and chromogranin A. Serotonin metabolism and metastasis to the liver. Serotonin, or 5-hydroxytryptamine, 5-HT, is produced from the essential amino acid tryptophan and stored in vesicles in the Enterochromaffin cells of the gut and in neurons of the CNS and the enteric nervous system. After release, it is metabolized by hepatic and pulmonary monoamine oxidase, or MAO, into 5-hydroxyindoleacetic acid, or 5-HIAA. Carcinoid tumors secrete serotonin and other bioactive compounds that are released into the portal circulation and delivered to the liver, where they enter the sinusoids. Then the hepatocytes take up serotonin, or 5-hydroxytryptamine, and metabolize it using monoamine oxidase, or MAO, into 5-hydroxyindoleacetic acid, or 5-HIA, which is then excreted in the urine. So when carcinoid tumors remain confined to the gastrointestinal tract, the vasoactive substances they produce are inactivated before reaching the systemic circulation to exert their effects on the rest of the body. Thus, no signs or symptoms of carcinoid syndrome are observed in these cases. However, when a carcinoid tumor metastasizes to the liver, the metastatic nodules secrete serotonin directly into the hepatic veins and then into systemic circulation, allowing it to bypass liver metabolism. Elevated serotonin in the systemic circulation then leads to the signs and symptoms of carcinoid syndrome. There are 3 scenarios in which carcinoid syndrome can occur. 1. Liver metastasis from gastrointestinal carcinoid tumors. Here, the vasoactive substances bypass hepatic inactivation. 2. Primary bronchial carcinoid tumors. These tumors release serotonin directly into the systemic circulation without undergoing liver metabolism. As we will see later, bronchial carcinoid tumors can cause left-sided valvular lesions. But bronchial carcinoids frequently do not secrete serotonin when compared to gastrointestinal carcinoids. 3. Primary ovarian carcinoid tumors. Similarly, these tumors can secrete hormones that directly enter the systemic circulation. Clinical features of carcinoid syndrome. Carcinoid syndrome is a systemic disorder characterized by diarrhea, wheezing, and skin flushing, resulting from the excess release of bioactive compounds from carcinoid tumors such as serotonin, histamine, bradykinin, prostaglandins, kallikrein, and tachykinins. 1. Skin flushing. Mechanism. Increased levels of histamine and bradykinin cause vasodilation of skin blood vessels, leading to episodic flushing. Histamine may also trigger pruritus or itching. Presentation. Flushing typically begins suddenly, lasting from 30 seconds to up to 30 minutes. It most commonly affects the face, neck, and upper chest. Most flushing episodes occur spontaneously, but they can be triggered by food, alcohol, or emotional stress. Severe flushes may be accompanied by hypotension and tachycardia. Over time, prolonged vasodilation may lead to the development of venous telangiectasias on the face. 2. Wheezing. Serotonin binds to GQ-coupled 5-HT2A receptors on bronchial smooth muscle, stimulating bronchoconstriction. The patient experiences wheezing and dyspnea due to this bronchospasm. 3. Diarrhea. In the gastrointestinal tract, serotonin binds to GQ-coupled 5-HT2 receptors on GI smooth muscle, increasing intestinal tone and peristalsis. This results in diarrhea that is typically watery, non-bloody, and can be explosive, often accompanied by abdominal cramping. 4. Carcinoid heart disease. Elevated serum serotonin stimulates fibroblasts, leading to collagen deposition on the endocardium. This results in white, intimal plaque-like fibrous deposits on the valvular leaflets and the cardiac chambers, particularly affecting the right side of the heart because of exposure to serotonin that has bypassed liver metabolism. This valvular fibrosis leads to tricuspid insufficiency and pulmonic stenosis. In tricuspid valve regurgitation, the tricuspid valve doesn't close properly, so blood can escape from the right ventricle to the right atrium during systole, resulting in a hollow systolic murmur that is best heard at the left lower sternal border. In pulmonary valve stenosis, the pulmonary valve doesn't open properly to allow blood flow from the right ventricle to the pulmonary artery during systole. The left heart is usually spared because the pulmonary vascular bed contains monoamine oxidase, or MAO, that degrades serotonin into 5-HIAA. However, left-sided carcinoid heart disease may occur in cases of right-to-left shunts, for example, patent foramen ovale, or with primary bronchial carcinoid tumors, where serotonin enters into the pulmonary veins, bypassing hepatic and pulmonary MAO metabolism. 5. Mesenteric and retroperitoneal fibrosis. Serotonin stimulates fibroblast proliferation, resulting in fibrotic changes in the mesentery and retroperitoneal area. Extensive retroperitoneal fibrosis may cause ureteral obstruction and impair kidney function. Serotonin also induces a fibroblastic reaction in the bowel, which may lead to obstruction. 6. Vitamin B3 or niacin deficiency. Tryptophan, an essential amino acid, is a precursor for both serotonin and niacin. Excessive synthesis of serotonin by carcinoid tumors can deplete tryptophan, leading to niacin deficiency. Niacin deficiency, or pellagra, manifests with the classic triad of 3Ds: dermatitis, diarrhea, and dementia. Other findings include glossitis and angular stomatitis. So in a patient with carcinoid syndrome, diarrhea can be due to increased serotonin-induced bowel motility and due to niacin deficiency. Diagnosis of carcinoid syndrome. The preferred initial diagnostic test for carcinoid syndrome is the measurement of 24-hour urinary excretion of 5-hydroxyindoleacetic acid, or 5-HIAA, which is the end product of serotonin metabolism. Patients with carcinoid syndrome typically have elevated levels of both serotonin and 5-HIAA in the blood and urine. However, false positives can occur from the ingestion of serotonin or tryptophan-rich foods, such as avocados and coffee, or certain medications like acetaminophen. In addition, imaging studies, such as CT, MRI, or nuclear scans, are used to localize the primary tumor and identify hepatic metastases. The somatostatin receptor-based imaging techniques include the Octreoscan and the Gallium-68 PET scan, and they identify the number of cells that express somatostatin receptors. Most well-differentiated nets express high levels of somatostatin receptors and can therefore be imaged with radio-labeled octreotide, a somatostatin analog. These scans allow for whole-body imaging. With an Octreoscan, a radio-labeled octreotide is injected, and it binds to the increased number of somatostatin receptors on tumor cells. A gamma camera then detects the radioactive octreotide signal, generating a whole-body image that shows where the tumor is. Another somatostatin receptor-based imaging technique is the Gallium-68 PET scan. It uses the same principle, with radio-labeled octreotide injected, but integrates PET scan. It is more accurate at detecting neuroendocrine tumors because of that time. It offers a higher spatial resolution and improved sensitivity for detection of small lesions, including occult primary tumors. So somatostatin receptor PET imaging is preferred over Octreoscan. Ultimately, the diagnosis is confirmed by biopsy, which typically reveals round blue cells arranged in a rosette-like pattern. Immunohistochemical staining will show positivity for neuroendocrine markers such as synaptophysin and chromogranin A. Surgery is the treatment when the carcinoid tumor is localized. Somatostatin analog, for example, octreotide, or tryptophan hydroxylase inhibitor, for example, Telotristat, are used for symptom control. 1. Octreotide. Octreotide is used to treat symptoms of carcinoid syndrome attributable to serotonin, such as diarrhea. Octreotide is a somatostatin analog that binds to the somatostatin receptors and inhibits hormone release from neuroendocrine cells, including many gastrointestinal hormones. So octreotide is also used in the treatment of acromegaly, VIP homa, and variceal bleeding. 2. Telotristat. If somatostatin analogs fail to control symptoms of carcinoid syndrome, for example, if diarrhea is refractory to somatostatin analogs therapy, a tryptophan hydroxylase inhibitor like telotristat can be added. Telotristat inhibits tryptophan hydroxylase, the enzyme responsible for the rate-limiting step in converting tryptophan to serotonin, thereby reducing serotonin synthesis and alleviating symptoms associated with carcinoid syndrome. Thank you for watching this clinical overview. If you found the video helpful, please like, share, and subscribe, and don't forget to leave your comments below. Until next time, happy studying and good luck.